I've had a semblance of control for 24 hours. I'm feeling it slipping away. People must, have something to do with the noon hour on Friday or something like that. Many of you are probably aware of a series of meetings under the title Collaborating Across Borders that has now been convened 3 times in a collaboration across borders between the United States and Canada. And before Malcolm kicks off our next panel, Leslie Bainbridge from UBC is going to give us a cameo on the 2013 CAB 4 meeting. Thank you.
Thanks very much, Lucinda. I'm really privileged to co-chair CAB 4, Collaborating Across Borders with Dr. Susan Meyer from Pittsburgh. And so we've been working feverishly over the last few months to start to plan this conference. The CAB 3 in Tucson last year was highly successful with about 750 registrants. We're anticipating probably at least 1,000. And it will be in Vancouver, June 12th to 14th of next year. We're trying to really look at the practice setting and the education setting, and we're really trying to focus on patient involvement. So our keynote, who will start and end the conference, is a patient advocate, Regina Holliday from the US. She's also an artist, so she will paint throughout the conference, and there will be at least 2 paintings that we will be able to either give away or raffle off as she closes the conference and explains the significance of the paintings. We've also really tried to encourage students to be involved in the conference, and so just as of last week, our National Health Science Students Association has decided that they're not going to have their own conference, which they had originally decided to do. They want to really embed students in our conference. And so we're looking now, how can we really strengthen that student presence and really encourage students to come? We'd like patients to come, family advocates to come. We want students to come, practitioners. We'd really like to see the practice side in the conference, as well as the educational side and as well as the research side. It's at the lovely Hyatt Hotel in downtown Vancouver. There's lots of opportunities for vacation before and after the conference. And there is a one-day conference that we're small P in partnership with the day before our conference, which is the Canadian Association of Health Professional Education, so a continuing education conference. And there will be a slightly adjusted rate for people who choose to go to both conferences to see if we can support each other. So I just wanted 2 minutes just to remind you of the conference. We think it'll be a fabulous conference, building on the previous 3 fabulous conferences, and we would look forward to seeing you all there and all your colleagues there. So thank you, Lucinda, for the time.
Thank you. That's really terrific and a pertinent announcement at this point. But it has taken 5 minutes of my time. So unfortunately, I'm not going to be able to sermonize about things today, which probably many of you would be grateful for. The next 2 sessions, and there won't be a break between them, remember now, we're just going to go from one directly into the next, is really what you've all been waiting for, or at least what all the frustrated academics in the room have been waiting for. And I suspect that there are many frustrated academics in the room. And that is how to really begin to think about joining the academic community with the practice community. And unless we can really have exemplars and ways of doing that, and some principles and some steps to move forward, it's going to be very difficult for us to create the kind of interprofessional practice and the education that's necessary for interprofessional practice, which is really what's going to reform and transform our health system. So the 2 have to come together, I think. And the ways in which we're going to bring that about are not entirely clear. It is clear that our health systems are going to have to transform if for financial and no other reason. What is much less clear to me is whether the academic community will be partners with them in doing that, or whether they will be dragged along reluctantly. And obviously, I don't think that applies in this room, but this is not a microcosm of the academic community nationally, at least in the United States. So dragged along or willing passengers is really the theme that I wanted to bring about. So in the first hemi-session of this next session, we're going to begin to deal with some exemplars, some models of how education can be transformed within the academic community. And I would ask you all to think, as you go through this session and the next one, around two sort of models of that transformation. One is the inoculation model. That is, you put some small, relatively circumscribed experience in place that serves a purpose for the patients and the trainees in that particular inoculum, with the hope that maybe it will spread throughout the institution or more broadly into other institutions. And the other one is the kind of approach that is a pandemic, that is an interstitial approach, where an institution makes a decision, or a group of institutions with their practice partners making a decision to do something different. And they're very, very different approaches. And the change of cultures that are necessary, the kinds of skill sets, the kinds of assessments, almost everything that need to be brought to bear are going to be tailored, will have to be tailored by which of those two approaches there is. And of course, they're not isolated approaches, they're just two ends of a spectrum. One is more traditional, the inoculum, the pandemic, or the terrorist approach, as someone used, the revolutionary approach, is a very different kettle of fish, but maybe they'll meet in the middle. So, with enough said about that, the first hemi-session then is the specific objective is to identify opportunities and challenges for student placements and projects in team-based models. And we have two examples of how academia and practice might work together to create a viable model of both training and practice by developing interprofessional teams. We have two speakers, and I'll introduce them both now so that I don't have to get up again. We can just switch them. The first will be David Collier, who's an associate professor of pediatrics and family medicine at the Brody School of Medicine of East Carolina University. He's director of ECU's Pediatric Healthy Weight Research and Treatment Center and an associate director for the East Carolina Diabetes and Obesity Institute, and he's vice chair of research for the Department of Pediatrics. Given that, he's going to talk about weight, right? How to control weight. So there's a message that David is going to bring to many of us that will be useful, certainly to myself. The second speaker is Steve Chen. Steve is an associate professor at the University of Southern California School of Pharmacy, and he's a licensed pharmacist. Dr. Chen holds the Hygeia Centennial Chair in Clinical Pharmacy at the University of Southern California for his work and leadership to improve medication use and safety in the community through clinical pharmacy services in safety net clinics. So let's start then with David, and then we'll switch over to Steve. And we're going to hold questions until the end.
Thank you, Malcolm, very much for the introduction. And I think what I'm going to do today is talk a little bit about our Comprehensive Healthy Weight Clinic, which is a component of our Healthy Weight Research and Treatment Center. I think it's going to fit very nicely into the inoculum model. I'm not sure if I'm a frustrated academician or not, but I guess we'll see by the end of the day. Now, Malcolm is a stern taskmaster. I normally think 2 to 3 slides per minute is appropriate. And he said I may not have more than 6 slides, so I have chosen them to be very complex.
So the density of the slides.
Yes, I've even used one dense one twice. But at any rate, he maintains the right to cut me off if I go over 10 minutes, I think. So I think most experts would agree that the concept of obesity is really a concept of an imbalance in health behaviors, and seen at the middle of this slide is the health behaviors that we think matter, which is an imbalance in energy in and and energy out. So obesity really is a fairly simple construct at some levels, but actually it's a really complex biopsychosocial disease, and it's the result of the accumulation of a number of inputs across really two kinds of axes. And what you see on this slide is a hierarchical axis that moves from the bottom of the slide upward, starting at the micro, individual DNA gene level, all the way up through the macro level. And so at the bottom of the slide on the lower right, we see that, and actually before I proceed, I should say that this is the framework slide for the Children's Health Model, Children's Health Study, which will be the largest funded study in the world now, looking at 125,000 maternal fetal dyads across their lifespan up to early adulthood. So this framework acknowledges that there are things operating at the micro level, so at the gene expression level, epigenetic level, that may include chemical exposures, nutritional stresses that influence our hypothalamic pituitary axis, our appetite, our mood, our metabolism, and that these indeed influence these two important health behaviors. And then as we move up into the macro level, we see that things such as psychological hazards, our built environment, whether we feel it's safe, what kinds of TV kids are seeing, local fast food environment, all the way up through laws, regulations, health policy, et cetera, influence these behaviors. And then the second axis that's important is the time axis, and that moves from left to right, and that's shown in red, and that these factors come to bear on the individual across their lifespan, either from conception or even preconception through gestation, through early life cycle, and across the span. And over time, these influence these two key health behaviors, energy out and energy in, such that we gain weight. And then as we gain weight, we certainly begin to have health outcomes, and these can feed back or feed forward onto the tendency to develop disease, such as lower extremity dysfunction, shortness of breath, keep us from being active. Therefore, we become more obese. Therefore, we become less active. So that's a nice framework. So I think we have to acknowledge that obesity is a complex biopsychosocial construct, and as such, it is a perfect problem for IPE, IPP. It's crying out for IPP solutions. And I'm going to tell you a little bit about our approach to that. So the second and even more complex slide, which Malcolm is not acknowledging, is represented here. And in 2007, the AMA, CDC came out with consensus guideline statements about what we should be doing for childhood obesity, and the state of North Carolina codified this 100 and some page expert consensus opinion onto a one pocket-sized sheet here, shown here, about what we should be doing. And basically, green is good. Kids that are green are healthy weight, and we should just be providing healthy weight messaging, prevention messaging. But as we begin to move to the yellow section where BMI exceeds a healthy BMI, to light pink to dark red, we get more and more complex. And again, I think I'll just go to the next slide because it's a little more clear. What the consensus expert panel says we should be doing about this, and what the state of North Carolina has reduced this to. So as we get into pink, these would be kids who have a BMI above the 95th percentile, maybe some comorbidities, maybe they've had some involvement, health, weight maintenance or weight interventions, but not responding well. And then when we get to the bottom dark red box there, these are kids at the 99th percentile or having a lot of comorbidities. So what we should be doing is we should be having clinicians, and this does not mean physicians necessarily, but clinicians who are trained in weight management. We should be using motivational interviewing or patient-centered, family-centered approaches. We really should be using registered dietitians, and then we should engage the community in physical programming or physical activity programming. We should be using cognitive behavioral therapy approaches. We need to engage the whole family. And then as we progress down further to that last dark red box at the bottom, we may need to advance what we do to include residential treatment protocols, very low calorie diets, liquid calorie diets, even bariatric surgery. And then on the bottom left there, you see multidisciplinary team is really crucial for this. So this is our version of the staged approach. So our stage 3 treatment is what we call our comprehensive healthy weight clinic. And it really is, I like to describe it as a three-legged stool sitting in a pool of motivational interviewing or behavior management, because this is really our tools available to us at the level of the patient. The patient with extant obesity and complications really is behavioral management. We may have missed the boat on what their in utero exposure was. So what we need to do for the patient now is to try to promote healthier behaviors. And so we really think we have three main components: the medical component, the nutrition component, and the physical activity component. And on the medical side, it's really our job is to identify and treat medical causes or complications of obesity. As most people know, there are very few true medical causes. It's mostly behavioral. We really need to promote positive behavioral changes. We need to help the family recognize their role responsibility in the issue, and then consider referral for appropriate services. What I didn't put on this slide, which I think is a little unique to our clinic, is we actually have a periodontist on staff who is integrated into our clinic, and this is in recognition of the fact that obesity is an inflammatory condition. Inflammation drives insulin resistance, it predisposes to type 2 diabetes, and that oral health, gum disease is a very pro-inflammatory condition, and that medicine and dentistry traditionally have been very separate. And so we've had the luxury of integrating periodontist into our clinic and provide this service for these patients. And of course, cardiogenic lifestyles and obesogenic lifestyle as well, so there's a lot of overlap there. Then in terms of nutrition, we have an embedded nutritionist. She sees all of our patients. There are certain messaging that we use that seem to be evidence-based. But in addition to providing nutrition services, we've also developed the medical nutrition therapy protocol, and that was really driven by Dr. Kathy Kalasa, who's at ECU and has been a good mentor to me. And we also measure resting energy expenditure because that is recommended as standard of care for adults for obesity treatment. We also think it's good to do this in kids, and I'll speak more about that in a minute. Then in terms of physical activity, there are certainly behaviors we try to promote in terms of increasing active time, decreasing sedentary time. But promoting physical activity is one of the biggest challenges in our Healthy Weight Clinic, because we don't have any professionals who are licensed and can be in there providing the service, providing the recommendations for physical activity or giving us a physical activity prescription, if you would. But we do work very closely with our pediatric physical therapy colleagues, more on a research basis and a referral basis. But working together with them, we have been able to identify that there's a specific obesity-related lower extremity dysfunction, and that we try to address that to help keep kids active. So I guess I would describe what we do as collaborative, co-located, and integrative. And what do I mean by that? So collaborative, certainly we work together, and there are lots of collaborative approaches. So if I were to see a patient and refer them to the physical therapist, hopefully we would collaborate together. But we try to bring as many services together as we can so that we are co-located so the patient can see all the services at the same time. And then integrative, by that I mean that we try to work together in real time to develop a plan that best fits this patient and this family, using inputs from all of the providers represented on the team. So who might those be? Well, certainly on the medicine side of things, these can include pediatrics or med-peds residents or family medicine residents. It can include medical students, and it can include undergraduates who wish to go to medical school. We do provide an opportunity for nursing students. This tends to be a half-day shadowing experience, so we haven't really developed a robust role for them yet. I see the nursing folks shaking their head no. This is really a very robust opportunity for those in the behavioral sciences, and we're lucky to have a PhD program in medical family therapy at East Carolina University, and we've become a placement site for their master level students. And this was a lucky accident that they needed placements and we needed this service. So the kinds of things that these students can do for us is they can take the time with patients that the physician may not be able to take to understand the family dynamics, the barriers to change, to help promote that, address the issues that are common in childhood obesity, including bullying and issues like that that are critical to address but may be difficult for the physician to do as they have to move on to the next patient. They also help us address things like if we unmask a suicidality in a patient, they can handle that. Because our institution, we don't have a pediatric inpatient psychiatric ward, so our options are to call the sheriff and have them handcuffed and driven away in a sheriff's car. So we don't mind asking those questions because we have these students who are well enough trained to handle this issue for us, and this has been a very rich environment. Then certainly nutrition, our dietitians is providing service as a clinical member of the team, but we also serve as a site for registered dietitian students. And more importantly, I think for us in terms of interprofessional education is that our nutritionist, dietitian actually serves a very important role for educating our residents and medical students on how to approach nutrition and give them some practical information that they may not be getting through our more didactic curriculum. And then again, physical activity, physical therapy is very important. There's a fairly significant gap there. And we really, in order to get services or involvement of these academic departments, it's more through research-based interventions. So here's some pedometers, good luck. Let's see what your counts are versus here's some pedometers and some cognitive behavioral therapy to help you use them. So what are some barriers and some lessons learned? Certainly there's some clinical and micro systems involved. Space, if we take a long time with a patient and we take 2 to 3 to 4 hours for an initial evaluation, certainly we're not turning our rooms over, and our clinical manager does not like that. If we use one room for one morning, that cuts into our overhead. Time, I guess this slide should read time, because it does take time to do this and to coordinate these interventions. At the institutional level, there are competing demands. So my chairman is fairly generous with my time and my money, and we don't necessarily have to make a lot of money, but we're not allowed to lose an excessive amount of money. And so this is a force in flux in terms of how are we doing financially. And then at the macro system, there are many barriers. For example, I have resident learners, but I can't let them do an initial evaluation on my patient because we bill for a level 5 consultation, and a resident is not allowed to bill for a level 5 consultation. So I have to do the whole thing over again, and I can't turn my resident loose to do that. So, or else it takes more time, more space, et cetera. And this, of course, runs all the way down through the other learners. Very important component to sustainability for this model has been the fact that North Carolina Medicaid has been very generous in terms of paying for medical nutrition therapy provided to obese patients. They have recently changed to say that the physician seeing the patient could not oversee the nutritionist for that day, so we started gaming the system a bit and having someone else serve as supervisor for that nutritionist for the day. But now North Carolina Medicaid is no longer paying for physician services and nutrition services provided on the same day. So this has become a huge barrier for our patients. Now they have to travel from 3, 4, 5 hours away. And so this is a macro systems issue. And Malcolm is, I feel him giving me dirty looks, and I will take questions, obviously, after Stephen has had a chance.
Thanks, David. So I want you to think, as Steve gets set up, about obesity is probably the major health problem for the population. So this is a really critical sort of area. And this is a potential model for getting at some of the training needed to deal with that.
Well, thank you. I'm really excited to be here today, and the proof of that is my heart's racing away. I don't know if it's because I'm nervous or because I had tea for the first time ever in the morning. It's driving me crazy right now. So I have 2 questions to run on, which are pretty simple. The first are, what are some ideal places to put IPE students? And the second is, what are some challenges that you might face when you're doing this sort of work? And I am a on-the-ground sort of person. I think of myself as an agent of change in some way. I'll explain that in just a minute. So the 3 settings where we have IPE students are areas that need help and desperately need help. And that would be obviously the safety net system, excuse me, geriatrics, and psychiatry, which was mentioned yesterday. Definitely prime areas for interprofessional education. In the safety net area, it's pretty obvious. Resources are extremely limited, space, supplies. There are very few specialists that are willing to see underserved. And so the primary care providers are heavily burdened to do a great job caring for those patients. We've seen remarkable shifts in the patients that we see as the economy continues to struggle. We start with minority patients in some clinics, and now we have every ethnicity you can imagine in the clinics that we partner with. Literacy, culture, poverty are huge barriers to not only adherence with medications, but complying with lifestyle recommendations, much of what David had talked about a minute ago. And we see providers just turning over all the time. This is a high-stress environment. It's hard to keep good physicians, unfortunately. So they desperately need our help. So the 3 programs that we have that involve safety net settings are the first being called SHARE, or Students Helping and Receiving Education. It's an 8-year-old program that was initiated by pharmacists, but now include other disciplines. We were one of the lucky 100 or so organizations that got a CMMI grant, and so we're basically developing clinical pharmacy services in a network of safety net clinics over the next 3 years, and what we learned in SHARE, we're going to apply to the CMS program. CMS program is only 2 months old, so I'm not going to talk about that too much right now. And then we have the USC student-run clinic. The difference between SHARE and the USC student-run clinic is that SHARE was a student IP program integrated into an existing practice, whereas the student-run clinic was created specifically for IPE by students. So this is one of those examples of get out of the way and let the students run it because they do such a great job. So we've talked a lot about measures, and the conversation's been fantastic. Again, my job as sort of an agent of change is trying to go to senior leaders in safety net organizations and other AmCare organizations and convince them to integrate clinical pharmacy services. The issue that we have is that clinical pharmacists, or pharmacists period, are not recognized as healthcare providers. And so this is a tough sell. They have to eat the cost of a pharmacist in order to buy into this. And so in most cases, we get a grant from a foundation of some sort. We demonstrate the value. And as that grant runs out, we were able to demonstrate the value in terms of quality improvement, safety improvement, and cost benefits. And the clinics end up picking up the tab for the pharmacist after that. So the bottom line is, when I'm trying to sell, whether it's pharmacy services or IPE students, I need to speak their language. They want to know, how is this going to help me in terms of the things that I'm measured by, the nationally aligned quality improvement measures, right? The National Quality Forum and Guideline Standards, for example. And then, of course, we have organizations trying to become recognized as patient-centered medical homes. How does this work align? And we have data that shows that our work absolutely aligns, and it's sort of the selling point that I give every time I give a presentation to a senior leader on why they need to adopt either students or our pharmacy program. The other aspect is that every discipline, we've talked about this, has their own unique contributions to the team. And that's not being captured too well. I think when we have an aggregate measure, we're getting an idea of what everyone's doing, but is there a way to quantify what these specific subunits are doing and in a way that's meaningful? And so for pharmacy, we have done that. We created a medication-related problem data collection tool, which is available on iPad, which is why I'm showing you this. And it was shared with HRSA in the Patient Safety and Clinical Pharmacy Services Collaborative. They've adopted it as one of their tools of choice for capturing medication safety data, but it does a lot more than that. If you look at the categories, there are 28 different categories of medication-related problems, which are aligned with several national standards and categories. We used some taxonomy from the Patient-Centered Primary Care Collaborative, from Medicare, and from NCC MERP in creating these categories. So just an example of how it's applied, in all of our clinics, we provide extensive one-on-one clinical pharmacy services for the highest risk patients. That's about 20 or 30% of most of the clinic's populations, and right now we have about 19 clinic partners. For the other 70% of the population or so, we hardly see them. And so we have a group of volunteer students, mostly pharmacy, but now, like I said, we're starting to get some PA and MD students that are joining us that then go out and provide med reconciliation to that 70% of patients that we hardly ever see. And so some of the initial data we got is that the majority of problems they're picking up on using the tool you just saw, which the pharmacists use as well, is that most of the problems have to do with non-adherence, but a little over a third have to do with medication safety issues. And those problems being dose discrepancy, differences between how a patient is using medications and how they were prescribed that medication, therapeutic duplications, and medication overuse and misuse of devices. Another example of some work that involves students, I chose asthma in this case. We basically work with any chronic condition, but I chose asthma because we have an asthma management service that's run by the pharmacist, but we have a monthly student-run program, a patient education program on asthma management. So the students come in and they hold a class that covers the basics of asthma, what the disease is all about, what the medications are, how to use the devices, and how you measure peak flow. And again, they do this on a monthly basis for patients that are enrolled in the pharmacist program. So these results reflect sort of the combination of our work and the students' involvement. And what this is basically showing you is that there's a threefold greater likelihood of patients reaching their asthma control goals as established by guidelines when they're involved in this program versus not being involved. Let me jump over to the student-run clinic, and I'm really proud of our students for doing this. This was initiated by all the different health disciplines that we have, and you'll notice that there isn't nursing in this list because we don't have a nursing school. Yeah, I was looking right at you. Can you believe that? We haven't. You're right. Okay, thank you. Darn, no excuses. All right. No, and, and it's a good point. You're right. That's a very good point. So we have not reached out to them yet. Even though this program is 3 years old, it's still a bit in its infancy in a sense, because as I said, it was developed for IPE, so it's not like they walked into a setting where it was already successful and well developed. But these are basically a few students that got together and said, you know, we don't want to wait for faculty to develop something. We want something that works well for us. And so they set out to do this. So again, medicine, OT, pharmacy, and PA got together. They found a physician mentor who's fantastic. He is at a couple of sites that are both safety net sites, the LA County Medical Center, as well as the Eisner and USC Medical Center. So those are the two settings where this program takes place. Each of the care teams are listed in the upper right-hand corner. There are 3 or 4 teams that run at any given time when clinic is in session, and the services provided are consistent with what you'd expect for those different disciplines. There's a question asked about cycle time, and what they've come up with is a very prescriptive cycle time of 70 minutes per patient. So it's shown here on the screen, and this has been a work in evolution. I was involved in the clinic in the very beginning, precepting as the team as a pharmacist, and the cycle time was 2 hours or something really horrendous, and so they really refined it quite a bit. And you can see that they have basically roles for every student member, where they spend anywhere from, I think, 10 to maybe 15 minutes with the patient, and then they have a huddle after all the different students have had a chance to apply their trade to that patient. They determine what the plan will be, and then implementation of that plan is done by whichever member of the team that applies to that plan. So they have this figured out pretty well now. It's been working very well, and the pharmacy student collects the same measures I shared with you previously, using that tool to collect medication-related problems. Some of the challenges that we have, I think some of these are repeats of what we've heard over the last couple of days. Probably I think the biggest challenge still is getting faculty to understand what other faculty do, other disciplines do. When I was involved in the early development of this program, I remember being at a session where different disciplines were sharing their thoughts, and then one of the physician leaders there who was representing medicine wasn't involved in any of the pre-training and just thought, this is ludicrous. And why are these people chiming in and giving their opinion on this patient? Okay, this is a problem here. So we've resolved that by hosting a series of seminars and workshops that run throughout the year, where we invite all faculty who are participating in these events to be a part of these workshops and learn about what other disciplines are doing. And we tailor it after the HRSA Patient Safety and Clinical Pharmacy Services Collaborative. We've not really had this problem much, students being disrespectful of students from other disciplines or just not getting team-based care. Maybe part of the reason we don't have it is because there are committed leaders that set the agenda as to what this is all about. It's made very clear at the workshops for faculty and students what established ground rules are in terms of behavior, in terms of interactions. It was mentioned previously, we encourage socialization among the different student disciplines, and you don't have to say much to get them to socialize. They seem to do that very well on their own. I have throw students into the fire. What I mean by that is every once in a while I'll get a difficult student who thinks that he's God's gift to healthcare. And so I'll say, oh, well, that's great. Why don't you go see this next patient at my homeless clinic? And I don't tell him that he was a recent parolee that is very easy to irritate. And once he gets through that experience, and he gets the idea that interprofessional care is a much better way to go. And then, of course, as faculty, we have to lead by example. I think that's something that we're still working on. We talked a lot about administrative support or the lack of it, and then questions about the efficiency. Is 70 minutes a reasonable cycle time, for example? And I think in the end, first of all, we need those advocates that are sold on this to be our advocates, and the leaders in whatever organization you're working with. And then, as I said before, we need to collect the data that demonstrates that this is important and meaningful and valuable to the institution that we're partnering with. It was mentioned yesterday that it'd be nice to align the schedules and curriculums for different disciplines. We're an old organization. To do that at our place is really tough. We've been trying, but I don't have an answer for that right now. But that's something we need as well in order to align this into the curriculum. Space is a huge issue. As you might imagine, in safety net clinics, you don't have a lot of room for all these students. And so we've had to pair up different disciplines and have different focuses at different visits in order to accommodate that problem. And in the end, I heard someone say once that, I went through a great IPE program when I was in school, but I've yet to see it in practice. And I think what we have to do is walk the talk and create more IPE programs that have the same vision as we have for our students. In the end, I just want to say that as pharmacists, we are really good collaborators because, again, we are not recognized as healthcare providers, and we're probably the only people nerdy enough to like to see this in our patients. These are the challenges that we love to face. This is actually one patient's medications, about 92 bottles of medication, half unopened, about $56,000 worth of taxpayer money wasted because she was not using her medications correctly. So thank you for your time.
So before we open the discussion, I want to mention that you can choose obesity or poverty as the major problem in the United States. But these two folks and these two sets of clinics are tackling real issues that are needed to improve the nation's health. And so this work is aligned with the outcomes that we want. Now, whether it's improving outcomes is a different issue. But I wanted to congratulate Steve for being the only person who's shown a p-value in this entire conference, which would probably make the older IOM happy. The new IOM, I'm not so sure. But in any event, there is data that at least Steve talked about a little bit with regard to outcomes, which is important. So the session is open for questions and discussion and comments. Polly. Start with Polly.
Okay. First of all, thank you both for showing the real importance of IPP and how students can learn from that on significant health problems. I want to point to a real problem that exists in our discipline and that could be helpful here, and that is that only 17% of the schools of nursing in this country are located in an institution that has an academic health science center. All right? That's at least the baccalaureate and graduate degree nursing programs in this country. So there are about 750 institutions that don't have a medical school as part of their institution. Then you may have other professions around in the area, and it's one of the places that I think interinstitutional collaboration is absolutely essential. I personally believe that USC should have a school of nursing, first of all. And Stephen, if you could go back and deliver that message. And it's been part of the hierarchical view of the status of nursing that's kept nursing out of USC. And I know that for a fact from conversations that have occurred with the leadership at USC. So I think we're delivering a message about the importance of the entire team to delivering good care. But in the interim, thinking creatively about how we bring people across institutional boundaries to help and address those really important needs. Nurses have to deal with medication reconciliation every day of their practice. They also see obese patients every day of their practice. And those are real issues for them to struggle with. And there's a good deal of research on obesity and behavior change that's being done in nursing too. So it can be helpful to both of your
So Polly, Steve is going to take your messianic approach to this back to USC, and I guarantee within 5 years there'll be an affiliation.
Okay, well,
Yeah, I know.
and other places there.
May I comment really quickly on that as well? I've been involved with the HRSA Patient Safety and Clinical Pharmacy Services Collaborative for 5 years now, and there are among the 200 plus teams across the nation that are part of this, many do not have pharmacists, and many are running this with nursing. So I absolutely agree with you. I didn't know about some of the politics, but now that I do, I will go back and send that message.
But PharmDs are extremely critically important to the nursing curriculum, and we collaborate extensively with PharmDs because we can't get the content. We don't have what you have.
Okay, so I think we need to move on. David, you had your hand up now.
Thanks for these really great examples. This question I think is for David, but for anybody that has an interprofessional program with students, is how are you within your program addressing issues of professionalism? And I guess specifically I'm looking at issues of advocacy for community, policy advocacy, community advocacy, moving towards system change like built environment, other policies in the community. One example might be vending machines in schools. So, you know, there would be so much of an opportunity to not just have physicians advocating for the obesity issue there, but nutritionists, nurses, et cetera, in the community doing that. And even dentists, and I would argue you should have a pediatric dentist instead of periodontist because of the magnitude difference in dental caries versus periodontal disease in this age group. But having pediatric dentists advocating for specifically that issue, not just as an obesity issue, but also a dental caries issue. So you could educate these individuals to rally around a common enemy, so to speak, or a common advocacy group. And I'm wondering how you're incorporating in this in beyond just the clinical treatment parts.
Great question. Start first with the dental issue. Interestingly, we have a very aggressive varnish program at our university, our School of Medicine, and it's really resulted in very little caries disease. And what we really see is periodontal disease in kids, like in adults. We would love to have a pediatric dentist, and now we have a School of Dental Medicine, we will have more involvement. We engage students. I think it's at a university. I mean, this is the business of a university if you really think about it. If you look at those inputs on what drives obesity, most universities have programs that address all of those issues, business schools, departments of ethics, et cetera, and that we need to somehow bring the focus of our universities onto this problem to bear. And there are examples. University of Georgia has done this. They've made this as a goal to address childhood obesity using the agencies within the university. At a ground level for us, we actively say yes to any student at any age, any level, any ability that wants to do something, and we will try to help them do something. So it'll be their idea. We mentor them. We have several different fellowship programs for rising M2. So they do this during their summer. So they may do nutrition education, physical activity promotion, et cetera, out in communities and develop programs. So we encourage that. The challenge with those are they tend to not be sustainable. And they may make an impact, a short impact, but we haven't found a way to capture that. And, like Stephen's program looks to be sustainable and focused. I'm not sure I really answered your question, but it's we just say yes to students as they come.
Spencer.
Thank you very much to both of you. Really enjoy your presentations, and I'm trying to integrate in my mind the ones I've heard earlier today, and with these. I'm with the Association of Schools of Public Health, and at a recent annual meeting, we had Daphne Kohler from Coursera talking about, and the thing about public health is that there's a core curriculum, and people are immediately saying, well, gee, why do we have to, all of us be teaching this thing? Maybe there's a possibility to use this incredible online, the other platform, there's another one with Harvard. So the question for you, because it's all institutional. Everybody's reinventing the wheel in a sense. And the person from South Africa this morning really talked about collaborative of collaboratives of collaborative, and that's extraordinarily important. But just if you could imagine, do you think there's a way to think about providing a basis for the students and faculty so that you've got a leg up when they actually show up in a way that could be integrated into the curriculum using a sort of it would require a common curriculum, an online thing. I'd be very interested in both of you just reflecting on that a little bit.
Well, I'll start on it. We have not succeeded in making this a common part of every curriculum at the school. That's certainly a challenge that we are trying to work towards. But I think one of the observations I've made is that during this meeting is you're right. Everyone is doing this work. Everyone is doing great work, but doing it different ways. And there are so many great practices out there. And people already talked about the collaborative model. It's worked very well for the Patient Safety and Clinical Pharmacy Services Collaborative, where you have, again, these 200 teams across the nation, all doing different things with different components of healthcare professionals, but all measuring the same core outcomes, but then also measuring other things that are unique to their organizations. I mean, I think that would work well for this group as well, to share best practices and promote those that are leading the way for others to follow as examples. I would like to see that. But in terms of integrating the curriculum, we haven't gotten that far yet.
David, do you have any thoughts about that?
Yes, thank you. And I forgot to mention, we do offer opportunities for our students in our Department of Public Health for their professional papers around issues related to obesity. I think certainly for obesity, this cannot be solved in a clinic. This is not a problem you solve in a clinic. It brings problems to your clinic, but it has to be solved across the spectrum of society. And public health plays a crucial role in that, because they're the ones that might do a public information campaign, for example, that can really change general behavior within a population. So this is the challenge is that it's a population health issue that then focuses or becomes an individual problem for the clinician and the clinical team to try and address in an almost isolated fashion in the clinic, when if the intervention of choice is improved nutrition and better exercise, if the built environment doesn't support that, if the advertising environment doesn't support that, if the food environment is a desert. So these issues need to be addressed for prevention and treatment, but a medical school model cannot, in my opinion, solve it. It has to engage elements all across the spectrum of society, including is it okay to spend $4 billion a year advertising directly to kids? Is it okay to make money on the backs of your question about vending machine policy in schools? In North Carolina, and Kathy can correct me if I misspeak, but our policy in schools is that to have free and reduced cost lunch for poor children, that we have to pay for that by food sales. And so, most kids are not shelling out money for peas and broccoli. They're shelling out money for the food coming out of the fryer. So we as a society have to decide that health matters over other issues. So public health is crucial for that.
So the issue really is around health versus healthcare and the integrative function that we've been talking about. And the inoculum model, as successful as it may be for a segment of the health problem in a particular place at a particular time, is not going to deal with public health issues. There needs to be a much greater integrative function here. Other questions?
I have two comments for the two of you. Urbanization, nothing about nursing. Urbanization is upon us. Half the world now is urbanized. In another 10 or 20 years, 75% of the world will be urbanized. With it comes poverty, and with it comes fast food stores and processed foods and lack of vegetables and fruits in neighborhoods. And actually, one of the people we need to engage with us is our urban developers, so that they can develop urban areas with the idea of walkability, connectivity, and stores. So that's one question to you as to whether even interprofessionalism and interdisciplinarity is not only about medicine and nursing and pharmacy, it's really about making an effect in society. So, and I would like you to comment on that. And for Steve, engaging with another school of nursing is not the only model. We found out, for example, at the University of Pennsylvania School of Nursing, that we needed a PharmD on the faculty. So I have a professor of PharmD. I have 3 professors of nutrition in the school. I have a professor of medicine. So I would like to encourage you to think about having a professor of nursing in your school until such time when you are able to collaborate with UCLA or develop another. I think that's where really we need to begin thinking about how interprofessionalism is really important in our schools. So I'd like to hear your comments about this.
Unfortunately, Steve is not the dean of the school or the president of the university, but he's getting there. So let's start with Steve and then turn to David.
Well, I'll say I completely agree with your statement. In fact, the PA school hired PharmD for their faculty. So the model is there, and it wouldn't be a big culture change to make that suggestion. So I love it. I'll make the suggestion. Thank you.
Well, and you certainly make a very good point that in the developing world, the problem of obesity and obesity-related problems, the WHO now says, are greater health risks than undernutrition. So this is a huge issue. Interestingly, in North Carolina at least, urbanization is protective versus obesity compared to our rural environment, which is an interesting research question. I think partly because people may actually walk more in an urban environment than they do in a rural environment where you must drive to get anywhere, or but at any rate, so engaging, yes. So I would view, when we have meetings, when we have summits, and et cetera, we invite, engage our colleagues from the planning departments, from the public health departments, from the state public health department, from NC State, where our School of Design is, and where they are interested in design and service of public health.
So we have about 5 minutes. I have 3 hands over here. Anyone on this side in the back who hasn't felt appropriately recognized yet? No one over there. This is an interesting left-right issue here. Please.
I want to thank David for presenting a really excellent example in the problem of obesity, where interprofessional education and care really can be merged. I'd like to point out a couple of things along with that. The clinical nutrition community might, in some ways, have been one of the vanguards in interprofessional education and practice, leading back at least 40 years, where nutrition support teams, when parenteral nutrition first became integrated into care, nutritional support teams included multiple disciplines: dietitians, nurses, physicians, pharmacists especially. And now obesity treatment is another one of those. So those sort of disease or therapy focused models are really good. Second point I'd like to make is up until now, I don't think we've heard dietitians mentioned among the various health professions that really need to be considered. So I'd just like to emphasize that point. Dietitians and many nutrition and dietetic training programs and internships are in our academic health centers, and please everyone, don't neglect to consider the dietetic and nutrition training programs in your institutions as you're thinking about developing IPE where you are. And the last thing is, I don't think there's really been a mention now, and this isn't so much for the panel as just for anyone, or maybe we'll have to talk about it later, but the Affordable Care Act is here to stay, isn't it now? We know, and I would be interested in you have brought up the issues of reimbursement and how our reimbursement structures for health care are counterproductive with regard to involving multiple professions, and I wonder whether the Affordable Care Act there might be some elements of that we could consider capitalizing on as we go forward in its implementation to benefit interprofessional practice. Thanks.
Stephen, my question is, for your student-run clinic, is this a service learning activity, or is this clinical credit that the students get for participating? That's my first question. And then are these students more likely to go into similar safety net practices, and have you recruited them for future preceptors?
Great questions. First of all, it is a service learning activity. These are volunteer students. They don't get credit for participating. They are fulfilling a critical need. So I can be more specific. At the LA County USC Medical Center, they're right next to the emergency department. And so patients are sent to them who come into the ER that don't really have ER issues, that are using the ER as a primary care source. And so they end up taking those patients and managing them according to the cycle that I showed you. Your second question regarding whether it encourages students to pursue careers in the safety net setting. We did a survey of our students who, before versus after participation in these programs, and we found that 80% changed their minds about what the safety net clinic was all about. 2/3 said that they would consider careers in safety net clinics, which they would not have before. And proof of that that's actually happening is we've expanded our number of residency positions in the safety net setting from 4 to 15. And we have 100+ applicants, most of whom are from our own school. So it's definitely catching on.
Terrific. Maddie?
My question is probably more for David. Because you're integrating students into this program, and we've demonstrated over and over in the years past that practice has really gotten the message that interprofessional care in a lot of these critical areas makes a lot of difference. But the question is, what do the students learn about collaborative care delivery when they're in your site? Because we've been debating, do you flesh out IPE explicitly, or do you just absorb it by virtue of being in a space where people are collaborating?
Well, I think our students have a broad range of experiences, from a nursing student for just half a day in a quiet shadowing role versus our medical family therapists who are actively serving as interns and meeting their hundreds of hours of requirements for internship. So the answer probably depends on who the student is, where they are, what level they are. I think we use the clinic to teach motivational interviewing to all kinds of learners because it's an important tool no matter what you do. So if you're a physical activity consultant or an exercise sports science major, you're going to be bargaining with your customers to be active. So there are sort of generic things like that that we hope students take away the importance of. And then and that's not necessarily interprofessional, but in thinking about this, I think naturally, philosophically, I'm very collaborative. In what's good about collaborative, what does it take to be collaborative, I think is a recognition or a valuing of other disciplines. And I highly value the other disciplines, and that is what I hope our students learn in these clinical settings, is that that we show that we value each of these disciplines by engaging them with the patient and then getting their input on the patient, on everyone's management. So I think that's the overarching take-home message for our learners.
So I wanted just to end the session by having us all reflect a little bit as we go forward around this issue of sort of de facto and de jure work, or what the sustainability of these interesting inoculations. And I emphasized at the beginning, this is about obesity and this is about poverty, if you think about it in a real sense. So these are important issues. These are not trivial issues that these two gentlemen are dealing with. And yet, I suspect if they left, or the champions who run these programs left, there would be a big transformation in the ability to go forward with these programs, even recognizing that students might drive it. But as long as this isn't really part of the curriculum, as long as these are simply service learning activities and extracurricular activities in that sense, we're not going to take full advantage of these important inocula. We're just not. So we've got to get this institutionalized in some fashion, because otherwise the gains are going to be lessened with time as other interests come along and pull people into other sort of interesting service learning activities. So let me thank Steve and Dave very much.